everyone. In this episode, I interview Professor Gavin Giovannoni about multiple sclerosis. If you enjoy these podcasts, please subscribe. I'm Dr Gail Busby, and this is I Forgot to Ask the Doctor. Hi everyone, thank you for tuning into the show. In this episode, I'm going to interview Professor Gavin Giovannoni about multiple sclerosis. Gavin is a consultant neurologist. His clinical interests are multiple sclerosis and other inflammatory disorders of the central nervous system. He is widely published and is considered globally to be an expert on MS. He's also very patient-centered, as evidenced by his MS Selfie online site. I feel honored to have him on the show. Gavin, welcome. Thank you so much for agreeing to be interviewed.
Thank you, Gail. Pleasure.
So, Gavin, I find it fascinating to find out why distinguished colleagues like yourself chose their field in which they work in medicine. So can you tell us why you chose to work in the field of MS?
Well, I always had an interest when I went to medical school, I was always going to be a physician. I knew very soon that I wasn't going to do surgery. And when it came to my first medical block, when I did my first rotation on the wards back in South Africa in year 4, the very, very first patient I clerked was somebody with multiple sclerosis. And I spent an hour and a half with her. And I think I was intrigued by not only the fact that this was a failing nervous system that I picked up in her, but also because of the immunology and the fact that I was also very interested in hematology. So as I went on in my career, I kind of decided quite relatively early that I wanted to do medicine and then neurology. And it was natural for me to do immunology as part of his neurology. So that's when I decided. I think it was imprinted in my brain very early.
Right, okay. And you never looked back?
No, I mean, people don't understand that multiple sclerosis is, because it's a disease of the immune system and it affects the nervous system, it kind of overlaps with quite a large number of specialties. So it provides you with a lot of different fields to research in and get interested in.
Okay. So, Gavin, as you know, this podcast is aimed at educating patients. So we try to avoid medical terminology as far as possible so that it remains as accessible as possible to everyone. So let's start from the basics. What exactly is MS? Are there different types or degrees?
So MS is what we call an autoimmune disease. So most people will know that their immune systems are there to fight really infections and prevent people getting cancer, and that's what they do. And with autoimmune diseases, the immune system goes awry, and instead of doing what it's meant to do, fight infections and cancers, that attacks your own body. And in multiple sclerosis, it attacks the nervous system. And we think it attacks primarily the myelin or the insulation around nerve fibers, and it causes these attacks in different parts of the nervous system. So that's what it is. We think it's an autoimmune disease of the central. It's the commonest autoimmune disease of the central nervous system. Now, some people will argue that there are different types. I would argue they aren't. There's just one type. It's multiple sclerosis. And what causes it to look differently from a clinical or a person's perspective is the type of damage it causes and the way the damage manifests. And I think we in clinical medicine call those phenotypes, what they look like clinically. Yes. But the biology, what happens in the brain and the spinal cord of people with different types of MS is probably the same process. It just manifests differently clinically.
Okay, that's really interesting. And I always ask about risk factors because there are various risk factors for various conditions, and some I guess you can't get around, like genetics. However, there are others that perhaps lifestyle modification can ameliorate the risk of getting a certain condition or decreases severity. Are there any identifiable risk factors for multiple sclerosis? Can it be prevented or minimized?
Well, we don't have very hard data that we can prevent it right now, but we do know that there are definite risk factors. So MS is like other diseases. It's called a complex disease because there's an interaction between genetic risk factors that you inherit from your parents and environmental factors. And then there's also bad luck, because the reason why I say bad luck is because the majority of people who live with those risk factors, both genetic and environmental, don't get MS. So the people who get MS must just be very unlucky, to be honest with you. And it's not a genetic disease in the classic sense that you pass on one gene or two, gene and a person gets the disease. There's multiple genes. There's over 200 that have been identified, what they call risk variants in the genome. But they're dominated by variants in the immune system. So it's the kind of genetics that dictate how our immune systems function that are the main risk ones. When it comes to the environment, there are a large number of environmental risk factors. So the dominant one, in my opinion, is the virus that causes glandular fever or infectious mono, Epstein-Barr virus. And I can be quite dogmatic about that in the sense that if people don't get that virus, they don't get MS. So the people who are EBV negative just don't get MS. So you have to have the virus to get multiple sclerosis. But most people get the virus. So, by the time you're 34, 35 years of age, 95% of the population will have been infected with Epstein-Barr virus. It's transmitted, throughout life via saliva mainly. So it's necessary to cause MS, but then you need all the other risk factors, and the other risk factors are important. So the one is lack of exposure to sunlight, particularly UVB, what causes vitamin D production. So it's either the sunlight or lack of vitamin D. We're not sure which one. This is why we have to do trials of vitamin D supplementation. So one of the ways that you may be able to lower your risk is if you make sure your vitamin D levels are maintained, at a high level throughout your life. To be honest with you, another risk factor is childhood and adolescent obesity. So being overweight when you're a child or adolescent is a risk factor. Smoking is a risk factor. People who smoke have got about a 50% higher risk of getting MS. And it's not just active smoking, it's also passive smoking, and it has to be cigarettes, because taking nicotine in other forms, particularly like snuff and non-burnt forms, doesn't increase your risk. So we think it's actually it's got something to do with the lungs, because another risk factor is being exposed to organic solvents, in the chemical industry. They also up your risk of getting a multiple sclerosis. Female sex, females are more than double, twice as highly, more, they're almost twice as likely to get MS as a male. So that's something around being female. We don't know what it is. It could be female hormones. I suspect it's more complicated than that. So, and there are some things that reduce your risk. Coffee consumption, for example, reduces your risk. Being infected with another virus that's related to EBV called cytomegalovirus, CMV, actually reduces your chances of getting MS. So there are some factors that reduce your risk of getting MS. So it's quite a complicated story, but setting up at the top of the causation pathway, what we call the causation pathway, I like to think of it like dominoes, as Epstein-Barr virus. If you take out the Epstein-Barr virus, all those other dominoes can't fall, and you can't get MS. So that's the kind of analogy I like to think about it, like falling dominoes.
Yeah, that's fascinating. Okay, and what are the symptoms of MS? So what symptoms may someone have that might make them think, "Oh, perhaps this is MS. I need to go along and be checked"?
Well, to be honest with you, multiple sclerosis can present with almost any neurological symptom, because it depends where the lesions occur. And so the lesions typically have to occur in what we call an eloquent site of the nervous system to cause symptoms. And the ones that really, what I call report out earliest, are the ones that are sensory pathways. Part of the brain and spinal cord that is responsible for sending in sensory input. So the most common one is visual symptoms, blurring or loss of vision in one eye. It's called optic neuritis. Another one would be loss of hearing, buzzing in the ear, tinnitus. Another one would be pins and needles or loss of feeling in the arm or leg. So these are the commonest sensory presentations. Then we can also get types of neuralgias. If you get a lesion in the pathway that, for example, transmits sensation from the face, you get a condition called trigeminal neuralgia. And then it can also affect the pathways in the brain that actually control movement. So you may get weakness in an arm or a leg. You may get Bell's palsy, a facial weakness. So there's many different symptoms. There's even some rare manifestations. Some people presenting with chronic fatigue, for example. So I don't know if you know, in chronic fatigue clinics, about 3%, very small numbers, The first manifestation is fatigue. They go into these clinics and they found to have MS. Similarly, we may even get people affecting with memory problems. So in some memory clinics, particularly young people, a small number of those people, when they get investigated, are found to have multiple sclerosis, and the lesions are occurring in parts of the brain that are controlling
Yeah.
cognition, memory, and so they are very. We even got presentations where if a lesion occurs in a very specific part of the brain, causes a condition called narcolepsy. People fall asleep all the
Mm-hmm.
time. And I've actually seen a few cases where the initial presentation was narcolepsy, and they turned out when they had the MRI scans to have MS. So this is why it's such a difficult disease. There's not one specific symptom says that this is MS. We talk about MS, things that are the one that's very unique is when you get a lesion in the top of the spinal cord, usually in the sensory pathway. When people bend their neck, they get this shock-like sensation down their back. It's called Le Met sign, after a French neurologist, and that's kind of a very characteristic symptom of a lesion in that part of the spinal cord. However, there are other conditions that can cause Le Mets. But if a young person presents with Le Mets doing
Mm-hmm.
that, then they have about a 98% chance of having multiple sclerosis. Similarly, there's a particular condition that affects the way the eye movements work. And if you get a lesion in that pathway and it causes double vision, when we as neurologists examine those patients and localize and say that lesions occurring in that particular part of the brain, in young people, 99% of them will have an MS lesion there, and it's multiple sclerosis. So, these things people don't know, but we as neurologists, have we're kind of aware of these very specific presentations that hint at the condition being MS.
Okay, thank you. And so all these people who might be in fatigue clinics, memory clinics, or have that limit sign, how is a diagnosis actually made? So this may suggest that they have MS, but how is it actually diagnosed? What investigations are performed?
Yeah, so the way we define a disease, it's a clinical path. There's a clinical presentation, and then there's the pathology. Now, because we can't go and do biopsies of people's brains, we put forward a set of diagnostic criteria that we have to fulfill, and these diagnostic criteria are clinical, and they also involve what we call investigations, and those include imaging, MRI scans of the brain, and we do lumbar punctures, and we measure looking for immune dysfunction in the spinal fluid, and we do electrical tests of the different pathways. And then we ask the question, does this person have dissemination in time? In other words, two attacks separate, or two lesions occurring at least a month apart. And do they have lesions occurring in different parts of the brain and spinal cord? We call that a dissemination in space. And then we have to do other tests to exclude things that potentially can mimic MS. And once we're happy that there are no mimics and this person disseminates in time and space, and they say yes, then we label them, we diagnose them as having multiple sclerosis. But to be honest with you, Gail, even saying that, the diagnostic criteria are not 100% correct. Like all diagnostic criteria, there is a false positive and a false negative rate. And we know that in multiple sclerosis, that about 1 in 20 people that get given a label of MS don't have the disease; they have something else. So it's not 100%. So this is where it upsets people. But we in the field of neurology, we actually don't do too badly. In other conditions like Parkinson's and Alzheimer's disease, for example, the misdiagnosis rate is much higher than 1 in 20. So we feel our diagnostic criteria are reasonably good. That's not the problem, is the diagnosis. What the problem is getting into the system. So what we find is that when people with these complaints go to their family doctors, they often get directed to other people. They often get directed to ophthalmologists, maybe to neurosurgeons, to orthopedic people. And then what happens is there's an enormous delay, or their symptoms resolve when they don't get investigated. And so what happens is the biggest problem we have is that it takes, often months, years for people with MS to get diagnosed. And that's just because of the way the healthcare system functions,
Okay.
Unfortunately.
And that brings me nicely on to my next question, which is, so if someone had similar symptoms to what you're describing, how urgently should they seek medical attention? And does earlier diagnosis affect progression of disease, earlier treatment? What would you recommend?
Yeah, so I think overwhelming evidence now, not only from clinical trials, but also real world evidence. So this is when I'm saying people in registers shows that delayed
Mm-hmm.
diagnosis, delayed access to treatment, and even delayed access to more effective therapies all come with a worse outcome. So I wish I could give you a figure, but there's no doubt that what I would call
Yeah,
delays in the diagnostic and treatment pathway have consequences at a group level and probably at an individual patient. I've got lots of examples from my personal
yeah,
practice where I can say that this individual almost certainly has done badly because of delays. And that's one of the things. Now, I would like to say to you that GPs should treat this as an emergency, but there are lots of other conditions that also are urgent. And multiple sclerosis is not about hours and days, but probably weeks and months make a
yeah,
difference. And we've got such a backlog in the NHS now post COVID, and
absolutely.
the GPs are completely is that they triage patients, and they often, particularly if the symptoms resolve, they often don't think about multiple sclerosis, and they say, "Well, come back if something happens," and that's where we've got to try and educate general practitioners to be a little bit more proactive and not to just pass off a transient neurological symptom as being
Yeah.
irrelevant. Say, well, could this be the first manifestation of a demyelinating event, of an MS
Mm-hmm.
event, and then let them come to us as neurologists when we'll investigate them and hopefully make a diagnosis earlier. And this is one of the reasons why I led on this campaign called we did a policy document, time matters in multiple sclerosis, to try and uh, activate the MS community to treat multiple sclerosis more proactively, and that includes
Yeah,
diagnostically as
yeah,
well.
yeah. And that's the ethos actually of this podcast. It's all about education of patients, of GPs, to have earlier recourse to treatment. Okay, so my next question is: are there any other factors that can influence progression?
Yeah, so obviously, uh, I've kind of hinted that untreated MS, leaving multiple sclerosis active, these lesions coming and going. And I want to point out to your listeners is that for every clinical attack, which we call a relapse in multiple sclerosis, there are 10 or more lesions that come and go in the brain and spinal cord that people with MS are not aware of. And the reason is they're occurring in areas where they're not eloquent, either because that particular pathway has reserve, so a small lesion doesn't cause any
Yeah.
symptoms, or they're occurring in parts of the nervous system that don't bring out obvious symptoms, but they're still causing damage because under the microscope, those lesions are causing nerve fibers to be damaged and they die off over time. And what happens then is when people lose their reserve, their ability to compensate for damage, they present with what we call progressive MS. So clearly, we have to treat this disease to stop these new lesions coming and going. But in addition to that, the brain is like any other organ. You can make it unhealthy or healthy depending on how you live.
Mm-hmm.
And there's this whole concept now, and the World Health Organization has put forward this document about brain health. And this is basically how do you make sure your brain is healthy so that when you get to old age, you can age
Mm-hmm.
normally or age well. And MS is no exception to that. So things like smoking, drinking too much alcohol, not sleeping properly, head injuries, taking medications that damage the brain, for example, possibly poor diet, all these things that have a negative impact on our brain function are also bad for people with multiple sclerosis. I see you, Gail, you're a woman, so we now know that female hormones are good for the brain.
Yeah.
And HRT, for example, is anti-aging. It protects the brain against some of the effects of aging. So, I personally begin to recommend to all my female patients when they start getting towards menopause, I think all MS patients that are women should probably consider being on HRT because it is anti-aging and potentially, and there's evidence that women who go into early menopause and people who don't go onto HRT do worse than women who go onto HRT. There are trials running to test this, but there are other reasons why women should be on HRT, and I think there's a lot of activity happening not only in neurology but across the medical spectrum, suggesting that there are real health benefits to HRT, and one of them is brain health. So
Yep. So I've done an episode on that, so I can direct listeners if they want more information to my menopause
well,
episode.
the other thing that's come out of COVID is social determinants. Now, it's hard to impact on social determinants. Social determinants are really in the deprivation. How educated you are, how much exercise you do, but some of these are potentially modifiable. And the one I think is modifiable is loneliness, social isolation. And we now know from psychiatric conditions, there's this concept called social capital. It's not money, but it's how many people you have in your social network are good for the brain. And our brains are really important to feed them with social interactions. So as soon as you isolate yourself and you're not having lots of social interactions, I think your brain withers in a way. It's not getting the
Stimulation.
stimulation. So one of the things that could be done from a social determinant, if we do pick up people that are socially isolated, lonely, can we get the general practitioners to do social prescribing, get these people to into community-based programs where they start interacting, meeting friends, increasing their capital. So there are some social determinants that can be modified. And that's just a new field, to be honest with you. We don't really have a big, strong evidence base in MS, but I suspect based on the principles behind social determinants of health, MS is not going to be any different to depression and schizophrenia and all the other conditions that have been shown to have where social determinants are really important in predicting long-term outcome.
Okay, so moving along the treatment, the patient journey, the patient has now been diagnosed or given the diagnosis of having multiple sclerosis. What treatment options may be offered to them?
Well, there are two big treatment options. So the first are the so-called disease-modifying therapies. So these are drugs that affect the natural history of the disease. In other words, reduce or stop relapses and delay these people becoming or prevent them from becoming disabled. And now we have over 15 of those, and they're different tiers. So there's what I would call platform, which are moderately effective. Then we have a middle tier that are highly effective. Then we have another tier that are very highly effective. And I don't want to confuse your listeners, but there are quite strict guidelines based on the trials and the cost of these drugs that the NHS has done. They use NICE. They do these things called cost effectiveness analyses, and they're quite strict guidelines on how we use these treatments. And it also depends on how active the MS is. So some people that have got very, very active MS can access the most effective therapies from the very beginning, and people who don't have very active MS and have a good prognosis profile, will have to start off on the platform therapy. So there are many factors that come into who can get what treatments, but the important thing they are treatments, and there's no doubt that we've completely changed the prognosis of MS with these treatments. And anyway, even if you go on to one of the lower tier treatments, if you don't respond and those treatments don't work on you, we'll move you up to more effective treatments, relatively quickly. So I think overall, the important thing is if you have MS and you are active, having relapses or new lesions coming and going on your MRI scan, and for that we have to have monitoring. So we do monitoring scans on our patients every year. That's part of our assessment of them, and we would change the treatment depending on how they're responding to the current therapies. So that's what we call disease-modifying therapies. And then obviously people with multiple sclerosis, depending on how much damage or where the damage has occurred in their nervous system, they may have problems as a result of and then we treat the symptoms. So the kind of things that happen is bladder problems, bowel problems, fatigue, potentially unsteadiness of gait, tinnitus or vertigo. So, walking problems, spasticity, pain, depression, anxiety. These are all other complications that occur from having MS. And then we have to go through, we have a pro forma essentially a list of things we ask our patients when we see them in
Right.
clinic, and we then target their symptoms. Not all of them need medication. A lot of the things, for example, can be managed, without medication, and a lot of them can be self-managed. Some of them can be self-managed. But I think people with multiple sclerosis have got to realize it's not just about disease-modifying treatments. There's lots we can do to manage the symptoms and improve quality of life. Because at the end of the day, what we're trying to do is keep these people free of the
Mm-hmm.
symptoms, functioning
Mm-hmm.
normally, hopefully keep them employed or keep them in university or school, depending on their
Yeah,
age, and keep them, as normal as possible. And I think, the current generation of people developing MS have got so much better prognosis and outcome than people that were diagnosed, say, 20 years ago. We've really transformed the field.
that's fantastic, and that's great news to hear. So, in terms of the treatment options, are there any risks or side effects that you think it would be useful for people to be aware of? And I know if you have so many treatments, that must be quite a long answer. But any that you think are significant enough that warrant special mention today?
Well, yeah, again, I mean, every single class of disease modifying treatment has its own
Yeah.
profile. But I think, I just want to make the point is that all medications have adverse events and side effects. And some of these treatments have tolerance issues. When people start taking them, they may get flu-like with interferons, for example, self-injection, they may get flu-like symptoms. We can manage those, though. We have strategies to improve the tolerance. So I personally don't think any of the tolerance issues, I don't think any of the adverse events or the side effects are not manageable. The important thing is to understand them and manage them. What people have got to realize, because MS is a disease of the immune system, most of our therapies work by dampening down the immune system. So they cause what we call immune suppression. And immune suppression puts people at risk of infections or maybe developing secondary cancers because the immune system. I must point out, though, that the level of immune suppression with our therapies is actually very moderate and is nowhere near as intense as other people. And so even in the COVID-19 pandemic, apart from one class of drug, you know, people who got COVID dealt with it very, very well. So it's not a potent immunosuppression. So what we do in practice is we screen people at baseline to make sure that they don't have any infections at baseline. We make sure their vaccines are all up to date. We make sure all their blood tests are normal. Then we initiate the treatment and we monitor them. And obviously, if they develop tolerance issues, we may have to switch them to another class of drug. If they develop infections, we manage the infections. So I just want to say to people, we can deal with all these things. We've got a lot of experience with our drugs now. I'd have to go through each individual class of therapy if you wanted me to go through individual side effects. But I want people to know there are other autoimmune diseases that have actually paved the way for us. So I don't know if you've done a podcast before on rheumatoid arthritis. The rheumatologists who look after autoimmune disease of the joints have kind of paved the way for us as neurologists to treat MS in a very similar way. It's about how do we manage the
Right.
inflammation with immune suppressive therapies, and how do we deal with immune suppression. But I think the message I want your listeners to take away is that we have effective and very effective therapies. And if diagnosed quickly and managed proactively, people with multiple sclerosis should not expect to be disabled. Or if they do get disabled, it's going to happen way in the future, because we don't have the answers. Some of these therapies have only been around for 5, 10
Mm-hmm.
years, so we don't have 20, 30, 40, 50-year data. But based on our understanding of this disease, we are anticipating that they're going to do extremely well over 40 or 50 years, with these
That's
treatments.
amazing. And as you said when you started, with all therapies, with all medications, their side effects, their risks, but we always balance risks and benefits. And clearly, it sounds benefits significantly outweigh any risks from the drugs.
Yeah. So, Gail, one of the things I could mention is, with all diseases, there's quite a lot of anti-science out there.
Mm-hmm.
And I just want to say to people, when they just surf the internet and the web, they will find websites that are promoting a alternative
Yeah.
treatment for MS. It could be aggressive lifestyle management. It could be, various therapies. I must point out that they must be very careful to check those out and make sure that there's consistency out there. And it's one of the reasons why I got into social media and started MS Selfie, is to deal with an anti-science movement. So I don't have a problem with people using complementary medicines, and some of them have a science base behind them, but they're complementary. They are in addition to disease. And I have a collection. I should actually put these together, of people who've actually not listened to us and have gone out and done an alternative strategy. And they come back to us 5, 10, 15 years later, and they're very disabled. And they say, well, I would like to go onto your treatments now. And the point about that, our treatments is to prevent disability. Once people have got a damaged nervous system and they are disabled, we don't have therapies to repair it. And so we've missed the boat. And so, I just, please be very careful about believing or adopting these complementary therapies as alternative treatments. I don't have a problem with complementary therapies. And I encourage some people to adopt these lifestyle management programs, but they've got to be on top of our current disease-modifying treatments.
Okay, that's a really, really powerful message, and really, really important to get out there, and very clearly and succinctly put. Thank you. And so my next question was, and I think you've kind of touched on this, if you can you give us an idea about how successful treatment can be, and what other factors may influence success rates? So apart from being on the therapy that is offered, prescribed, is there anything else? I guess sunlight, you mentioned that. I don't know if that's just for prevention or whether that helps to prevent the progression of the condition. Is there anything else that people can do to help decrease the risk of progression?
Yeah, so apart from early diagnosis, early treatment, it's looking like what we call flipping the pyramid, choosing the most effective therapies in the beginning. You're going to, on average, do better. It's like we talk about statistics, in life insurance actuaries. So on average, people on the most effective therapies will do better. Now, the more effective the therapy, they usually come with more side effects, or potentially more side effects. So what you've got to realize is you've got to take a little bit more collateral damage. It's like a vaccine. We know that when you vaccinate hundreds of thousands of people, you're going to have some people having serious adverse events to the vaccine to protect the majority. And the same thing happens in MS. If you put everybody on a highly effective therapy, yes, the group will do so well, but there will be certain people who have adverse events. And that's something people got to understand. So that's one thing you can do, is push for a more effective therapy in the beginning.
Okay.
And then adopt the lifestyle and these self-management interventions that I've mentioned. And also shop around. I mean, one of the things we find is, MS people often get gaslighted, they get ignored, and they get put down by various healthcare professionals. And so if you find alternative source information that you think are trustworthy, ask the question, and if they don't give you the right answer, ask for a second opinion, because a lot of what happens to people with multiple sclerosis is because of slow adoption of innovation. So, like in any field, a new therapy or new therapeutic approach doesn't always get adopted across the country. So there are some centers and some regions where they're still treating MS, like we treated it 10 years ago. They're allowing people to have ongoing relapses, ongoing MRI activity before escalating their treatment. And, so this happens in every field.
Yeah.
It's not unique to multiple sclerosis.
Absolutely, yeah.
Is sometimes your healthcare professionals are just not up to speed, and they're not adopting new treatment practices. And if you have doubts about that, ask questions, or get another opinion, because at the end of the day, you have to be proactive. You can't be passive when you've got a chronic disease. That's one of the reasons why I started MS Selfie. It stands for self-management. It's to empower people with MS to understand their disease and to ask the right questions, and where they can to self-manage their disease. Because we are. It started in COVID. I started the platform in COVID during COVID because we were redeployed to. I ran a COVID ward. Most of our staff were redeployed to COVID services, so we had a really skeleton staff running our MS service. And so the only way we could actually help people was to give them information to self-manage, to be honest with you.
Wow, it's amazing. Okay, so thank you for your clear and detailed answers to my questions. As you know, I ask our listeners to submit questions beforehand in order to ask our experts during the interview. Would it be okay if I ask you some questions that have been submitted by listeners?
Sure.
Great, okay. I must stress at this point that it is very difficult to give specific and personalized advice to patients without a thorough knowledge of their past and current medical history, examination findings, and investigation results. Also, due to time constraints, I've summarized the questions in a way that I think retains the essence of what is being asked. Therefore, these answers should only be used as a guide, and individualized care and medical management should be sought from one's own doctor. Okay, so the first question is, why is MS not as well funded as other conditions? My dad saw his MS nurse once in 2 years.
Yeah, very big question. So the thing about MS, it's too small a disease to get its own funding streams. So, we lump together under neurology. And in neurology, actually, the diseases that dominate are things like stroke, epilepsy, rather than, and headache, to be honest with you, rather than MS. So, we always have to try and fight our patch. So that's probably the main reason is that we fall under the neurology umbrella, and we're just a small little disease with all these other diseases, overpowering us.
Yeah, and I guess all of the specialties in the NHS also, everyone's fighting their corner for funding. Okay, the second question is, why is there not a multidisciplinary team instead of multiple appointments with different clinicians?
Yeah, so that again is about resources. So in some hospitals, there are multidisciplinary teams. So I used to work at the National Hospital for Neurology and Neurosurgery at Queen's Square, and we had a complex, what we call a complex MS clinic where people with multiple problems would go in, and there would be 4 or 5 different specialties there to sort out all their problems. Now, that's because the National Hospital is only doing neurology, nothing else. So they had the resources to do that. So it's really about resources, and also setting up a multidisciplinary team means you're pulling in 3 or 4 people for one patient. So it's not like, normally they do the budgets about, like a half an hour for a new appointment. When you got a multidisciplinary team, you're going to have 3 or 4 people. So you're using up a lot of what we would call NHS manpower, and those clinics then have to be costed and funded at a different rate. And when you go and do the business case and you apply to the funders, which is usually the general practitioners that hold the budget, they don't think it's necessary, and so it's just the way the NHS functions. I completely agree with you. We should have more multidisciplinary team meetings. That's the best way to manage people, because you can sort out all the problems in one go. But and instead of having, what I actually think is an alternative to that is creating self-referral pathways. If you've been given a diagnosis of MS, it should open up self-referral to, say, the continence clinic, to the speech and language if you've got swallowing problems. It should open up self-referral to podiatrists to cut your toenails if you can't do your toenails, for example. So potentially to dietitians if you've got problems with your diet. So I actually think that the NHS, instead of creating all these bottlenecks and roadblocks, is that once you get labeled with a chronic disease, and we know that people with MS have multiple problems, instead of having to go via your GP or your MS nose specialist or neurologist, you can actually then contact a specialist service and self-refer. This is the best. This is something that the NHS managers should understand. Is it just blocks, and the way the current referral system works is a roadblock, and it frustrates everybody. It doesn't only frustrate people with the disease; it frustrates us. Is why should they have to come via a funnel, to get access to care they need?
Yeah, agreed. Absolutely. Okay, our next question. What do you feel is the one single thing you can focus on that could be most important or rewarding in terms of life, health, and MS improvement? Or is it a more of a holistic thing?
So if you've got the disease already, it's got to be holistic. There's not one thing you can do. Okay, obviously, you've got to have a disease modifying treatment. You've got active, but then all the other things. I've got this concept called marginal gains. Gail, you must know about
Hmm.
marginal gains. So this is Professor, Sir David Brailsford, who used to run the British
Hmm.
cycling team. His whole philosophy is you improve all these little things by a small amount, you add them together, they make a big difference. I think the same thing happens in healthcare, in MS. If you put all the little things together, you have big differences. So this is why people with MS have to take responsibility. They have to take responsibility because I can't force them to stop smoking. I can't force people with MS to exercise. I can give them advice and help them stop smoking. I can give them exercise, which is the best exercise program. I can give them advice about diets. I can give them advice about sleep hygiene. I can sort out their pain. But at the end of the day, they've got to take responsibility, and it's about marginal gains. It's about having a treatment plan, and this is what we do as healthcare professionals. This is what you've got to do as somebody with the disease, and then we work together towards a common outcome. There are some people with multiple sclerosis who are incredibly passive. They think we can do everything, and they don't take responsibility for some. And I think this is one of the differences in the new generation of people with MS is they begin to understand that there's a partnership between the healthcare profession and themselves, and they have to take responsibility for some of that. So there is not one thing. Now, if you don't have MS, the biggest thing we can do is one thing: we can prevent the disease, but that's up to us as a preventive neurology community to do EBV vaccine studies and studies to try and prevent MS using vitamin D, treating infectious mononucleosis. There's quite a few things we're working on, but people won't know that. If we prevent MS, they won't know they would have got MS if they had this intervention. So it's a completely different approach, the public health one.
Okay. So you mentioned in your last answer that it's about patients taking responsibility. Um, Often people are happy to take responsibility, but sometimes they find it difficult because maybe they don't have a great resource to get the information. So the examples you've just given about sleep hygiene and lifestyle and diet and exercise, etc. Is there any resource where that's all pulled together that you can recommend for patients?
So I would say to people the MS Society in the UK, the MS Society, the MS Trust in the United States of America, there's the National MS
Hmm.
Society. They've got on their websites incredibly detailed information around this. Now, one of the problems people have, particularly recently diagnosed, they get overwhelmed with all this
Yeah.
information. So, and they also, it's like an onion. If you peel it too quickly, you cry because all this information, goodness me, this is going to happen to me. So
Mm.
I think people with the disease need to take it slowly. They need to realize it's a marathon, it's not a
Mhm.
sprint. And there are some people who just, they go into it like they go into it and they actually learn everything they can, and they eventually get burnout from that because they overwhelm themselves. So I think you've got to, set yourself um, a task maybe once a week, once a month and you acquire the knowledge over time. I mean, my MS selfie, I'm about to, it's kind of, it's free in the MS selfie, but people who can afford it pay a subscription. And the reason why I do that is I'm using the money from the subscriptions. And I want to thank people who do subscribe and pay. And I've hired a medical writer and a web designer, and we're going to create a curated website so people can. The thing about MS Selfie is, it's like blog. Things that I've written a year ago. You don't go through all the. You just like it overwhelms
Yeah.
you. So by creating a curated website, you'll be able to get indexes and search it much better and find the information with one or two clicks of the mouse or using the search function, and it's written in a consistent way by a medical writer. So we hope to launch it in the next 2 or 3 months. So that will be another resource is the MS Selfie
Hmm.
website. I call it a microsite. And MS Selfie is something you register, and I would send you 1 or 2 emails a week, and the information may or may not be relevant to you because it covers many, many topics. And I also cover research topics. People who subscribe have actually asked me to cover research topics. So some of the stuff may be, you don't want to listen to, you just delete it. But overall, the MSLFE website is going to be curated and indexed, and I think that's going to be a good resource when it's finished. It'll never be finished. It'll be a thing about,
Work in progress.
as things evolve, you've got to
Yeah.
put up new information. But at least the basic version, the skeleton, will be, very good resource.
Okay, so I will, if you're happy, I will put a link to the MS Selfie in the show notes for people, just makes it easier for them to find you, as well as the MS Society and the American Society as well. Just gives people.
So one of the reasons, Gail, what I was also warn your readers is I actually don't dumb it down. Okay, so the MS Society, for example, they told me they've got to write their literature and the information so a 12-year-old can understand.
Right.
Okay. And so a lot of people who go onto the MS Society website find it too simple and too basic and it's not detailed enough. I don't think the MS Trust applies the same rules. So the MS Trust is a little bit more detailed. Okay. So I actually personally prefer the MS Trust stuff because it's more detailed. Okay. And mine is above MS Trust. I actually don't pull my punches. I just realize that people don't understand. I try and write I try and junk the jargon, get rid of all the terms, but I also write it in a way that I'm expecting people to, be educated, understand things, and they can always ask questions. So I'm trying not to dumb it down. So I'm trying to pitch it at a level above MS Society and MS Trust. So depending on people's understanding and their literacy, etc., they may find the different versions suit them better. So the MSLF is not for everybody because I don't pull my punches. I also don't believe in rose tinted glasses. Some of the content on these websites is written in a way not to upset people. And I don't think that's right. If you've got a disease, you really need to know the warts and all. You know what I mean? People with multiple sclerosis have got to understand that it reduces life expectancy. And when people who do die with MS, they die from complications of MS. How are you going to make decisions about your treatment now if you don't know about what happens to people down the line? So I don't. It's not rose tinted. I give the facts, and so some people find that upsetting.
Okay, we're all warned. Okay, so the next question is: what does the latest evidence suggest in terms of diagnosis, treatment, and possible prevention of MS? Will we see EBV vaccination used in the future?
Yeah, so we've actually, I'm sitting on a committee of, I put a group together to try and work out how we would do an EBV vaccine prevention study. And to be honest with you, to test it for MS is just not possible. Yeah. What's likely to happen is there will be a vaccine to prevent infectious mononucleosis, which in itself is a good thing to have because infectious mono is actually quite an unpleasant illness. And what will happen is then we'll have to create registries once the vaccine's licensed to prevent infectious mono. We'll have to create registries at a population level to see what happens to the incidence of MS in those that have had the vaccine, and we'll know that not everybody will have the vaccine because there's quite a lot of vaccine hesitancy, and so we'll compare the incidence between the two arms, and if we can show that those who have the vaccine have a much lower risk of getting MS, then it'll hopefully convince the rest of the world or the rest of the people to have the vaccine. It's not only MS, by the way. People need to appreciate that Epstein-Barr virus has also been linked to some other autoimmune diseases. A condition called systemic lupus erythematosus, SLE, or lupus, Sjogren's syndrome, so we get dryness of the eyes, primary biliary cirrhosis, a condition of the liver, potentially rheumatoid arthritis. So there are other autoimmune diseases, and also Epstein-Barr virus causes some cancers, particularly cancers of the lymph nodes. So-called lymphomas. So an EBV vaccine that prevents infectious mono and prevents EBV infection may not only prevent MS, but may prevent quite a few other conditions. So there will be a whole hodgepodge of diseases in that registry. And it's exciting because I think, with the new vaccine technology, we have the opportunity of really making an enormous difference at a population level. I mean, Gail, you're a gynecologist. The analogy is HPV vaccination.
Absolutely, yeah.
And nobody. the final proof was when the HPV vaccine was shown to prevent cervical cancer,
Yeah.
and we think the same thing will happen in MS. EBV vaccine will prevent infectious mono, and downstream it'll prevent multiple sclerosis. That's the hope.
Well, that's really exciting. Okay, our next question is, do you foresee the use of stem cells in the treatment of MS? I banked cord blood for all of my children, and my husband has MS. Can it be used for him?
No, because the baby stem cells are not necessarily compatible with his immune system. So when you put those stem cells into the father, they're going to get rejected. So
Right.
the banking of the stem cells is really for that individual, the child, the infant, people think that these stem cells are there to repair damage. Well, we haven't shown that at all in any of the science that these stem cells go into the brain and repair. We do have a stem cell therapy we use in MS already. It's what we call hematopoietic stem cell. This is bone marrow transplant, and that stem cell is given back to people not to repair the brain and the spinal cord, but as to allow the immune system to recover quicker. So we used to do bone marrow transplants. Now we do stem cell transplants because we actually harvest the stem cells from the blood rather than having to put needles in the bone. But again, it just means that people have a recovery from the aggressive chemotherapy we use to ablate the immune system.
Yeah.
They recover now in about 2 to 3 weeks. In the past, without stem cells, we used to have to wait 4 to 6 or even longer weeks for that to recover. And that was when these people really get ill. That's where you get the infections and the bleeding and all that. So just to say to your listeners, hematopoietic stem cell transplant, which is a bone marrow transplant essentially, is a very effective therapy in MS, but it comes with many more risks. And we're actually doing a trial in the UK at the moment comparing hematopoietic stem cell transplant. So this is your own stem cells back into your body versus the high efficacy treatments to see how they pan out against each other in terms of effectiveness and safety.
Okay. Next question. After 16 years of having MS, I am now on Ocrevus and have not had a major relapse in 2 years. During that time, I've started to exercise regularly. Should I be doing aerobic or strength training? Also, despite no progression in symptoms, I still get very bad leg spasms at night. I take nortriptyline, but this is becoming less and less effective and I struggle to get a good night's sleep. Is there anything else that I could be doing? So 2 for the price of 1 there.
Yeah, so in terms of the exercise, outside of MS, so this is mainly in oncology and mainly in cardiovascular medicine, particularly after myocardial heart attacks, myocardial infarction. There's very good data showing you that HIIT, high intensity interval training, gives you much more bang for your buck. In other words, you get much more benefits from doing HIIT than you do from moderate intensity aerobic exercise. And there's a scientific reason for this. There's something about HIIT that really does rejuvenate or work against mitochondria and aging mechanisms. The mitochondria, those little things that make energy in your cells. So I actually say to people, if they can do HIIT it's personalized. It's based on how high you get your pulse rate. So for HIIT to work, you've got to get yourself close to maximum, above 90%, for a prolonged period of time, several times in an exercise session. And I've actually adopted HIIT. I do HIIT now 2 or 3 times a week just because I'm completely convinced by the data. And people, they may say, well, I can't do it. I'm in a wheelchair. Yes, you can do HIIT. There's protocols for doing with your arms, for example.
Right, okay.
It's about bringing your pulse rate up,
Right,
and
okay.
exerting yourself. It's tough. Anybody who does HIIT knows it's really hard and it's painful, but it's worth doing. And so I'm promoting HIIT now. But if you can't do HIIT and you don't like it, do moderate intensity aerobic exercise, and that's getting your pulse rate between 60 and 80%, I think the guideline is.
Okay.
And the WHO recommendation is to do 5 30-minute sessions, 150 minutes a week. With HIIT, you can do 3 15-minute sessions and you get the same benefits or more benefits. This person who's got spasticity and leg jerks at night, nortriptyline is just a old-fashioned tricyclic antidepressant that's quite sedating. It's given to help sleep. And, for spasms and spasticity, you need to use drugs that work against spasticity. And so there's drugs like baclofen, and there's drugs like gabapentin, pregabalin. There are the diazepam, benzodiazepines that we use clonazepam, which is a much longer acting. So there's a different class of therapy for that. So they'll need to go back to that individual will need to go back to their healthcare professional and ask them for better therapies that will help them with their spasticity at night. It's a big problem.
Okay. So next question. Despite being stable for several years and improvement of my motor symptoms, I still have lack of sensation from the waist down. Is this likely to improve in the future? I'm fully mobile, work, exercise, etc.
Yeah, so what dictates recovery of function obviously is
Yeah.
the extent of the damage that occurs with the original lesion. And then also how much reserve is left behind, and the age of the patient. The reason why I say this is age affects recovery of function. And so the older you are, the less likely you are to recover. And so this is, and also how long it's been there. So most recovery occurs within the first 6 months after an attack. We also see some recovery occurring up to 2 years, and very rarely after 2 years do we see recovery. Most of the recovery in function that occurs after 2 years is usually due to adaptations of the nervous system. Other parts of the nervous system take over. So I haven't answered the question because I don't have enough information. If this is a person who's had this sensory loss for 2 years or more, if they're over the age of, the age thing is variable, but really if they're over the age of 40, 45, it's unlikely to recover, and they've got to learn to live with it. If it was motor, sometimes you can actually train the nervous system to adapt to the damage, and the motor system sometimes is more adaptable than the sensory nervous system in terms of exercise and physiotherapy. But this person needs to work on that if they've got any other deficits. If they've got any motor deficits, they should really get into a rehab program and get given an exercise program by their physiotherapist to try and promote recovery.
Okay. And the last listener question is that my husband is Caucasian and has MS. I'm Afro-Caribbean. We have 2 mixed-race children and no other known family history of MS on either side. What is the risk of my son or daughter developing MS?
Yes, to be honest with you, the mother is much more of a risk factor than the father. So if it is a mother who had the disease, the figures we always give is the daughter has about a 1 in 40 chance, about a 2.5% chance of getting the disease, and a son, a male, would have about half that, about a 1.25, 1 in 80 chance. With the father, it's different, and it's probably about a tenth of that. We don't know exact figures for the UK, but in the Canadian data, where most of this figures come from, it's very unusual for the father to transmit or to increase the risk to the child. So I just want to say to this person, based on the Canadian data, the risk is going to be very low for her children getting MS. But what she should do is make sure that they have vitamin D supplements to keep the vitamin D levels up. Make sure they don't get obese, because obesity ups your risk. And if she can, convince them not to start smoking when they're teenagers. Because, as I said to you before, smoking increases we think that childhood obesity and smoking probably contributes about 20% of the MS risk overall. So it's not big, but why take the chance if you have got a family member with the disease?
Yeah, and get them outside and away from their screens.
Yeah, well, that's one of the problems we have. Is in the past we've have good data that outdoor activity lowered your risk of getting MS, but that was probably due to sun exposure.
Yeah.
And also what happens now is a lot of the makeup that the makeup industry, the beauty industry produces has sunblock in it. It has SPF 15 or higher, and even products that teenage girls use have got SPF in. So they're covering up their skin with sunblock, and they're not getting enough vitamin D, and it's endemic. It's across the whole of the UK. There is massive problem with vitamin D insufficiency and deficiency, to be honest with you. And so, I promote vitamin D supplements, and this is not an RDA, by the way, not the recommended daily allowance, which is trivial. It's an order of magnitude higher. So in adults, so 10 years of age and above, I recommend 4,000 units a day. and for a 2 to 10-year-old child, 2,000 units a day, and below 2, 600 units a day. And those levels are the kind of levels we think you need on average for immune function and hopefully to prevent MS. We don't know that for sure, though. We need to do trials, but those levels of supplementation are known to be safe.
Okay, brilliant. Thank you. That's really interesting. Okay, and so I've got one final question for you, and that's from me. You have managed in your career many, many patients with MS. Given the opportunity, what would you like to say to any person who either thinks they may have multiple sclerosis or have been diagnosed with it?
So yes, all I'm going to say, I'll repeat. I just think people with MS need to understand that we're in a completely new era. We're in an era where we have very effective disease-modifying therapies, and I'm pretty confident that the majority of people will live a relatively normal life, okay, with low levels of disability, and they'll be able to, achieve what they want to achieve. And going into the future, I think we may even be able to cure MS based on our understanding of what causes the disease. In other words, we'll put people into long-term remission, and we'll have to see what happens to them. And I think we've seen that already. There's quite a few groups of people that have had our most effective therapies that are in long-term remission, and it looks like MS has gone away. And I can't say we've cured them because we need to see what happens over 20, 30, 40 years, but it's looking extremely promising.
That's wonderful. That's really encouraging. So in closing, Gavin, the only thing that needs to be done is for me to say thank you. Thank you so much for agreeing to come on the podcast. Thank you so much for sharing your extensive wisdom and knowledge about MS with us. Thank you for helping in my effort to educate patients, and I know you are very enthusiastic about that yourself. But thank you most of all for your tireless work in helping patients who have MS and your extensive research into MS that gives a promising future to patients who have this condition. Thank you so much.
Thank you for having me on.
Okay. Thank you for listening. I hope you found it useful. Please keep your eyes and ears open for upcoming episodes. If you enjoyed this, please hit the like and subscribe buttons to raise awareness of this podcast.